measure this stuff in the urine, I mean, you've got a bladder catheterized, and then you've got to wait a long time because you can't empty everything out. It's just crazy. There is actually an incredibly accurate way of doing it without actually measuring anything in the urine. But you don't need to know that. If you're interested, I'll talk to you about it afterwards. But let's be pragmatic. Let's figure out what these people are wanting from us in calculations. It's nearly always set up this way. Okay? Questions? Is that the last page on the handout? Okay, let me do one more thing. No, there should be another page somewhere. I think there's another page. Well, I'm missing a page. I had it set up so that we... Okay, I've lost the page, so... Is that really the last page in the handout?
There's a summary of point. There's a summary.
Oh! Yeah, thank you. So, it's probably in that pile somewhere. So I thought before we got to the summary of important points, which you can read through yourself, we go through the second case. And, well,
You can go ahead.
go ahead, yeah. So, second case, 2-week-old breastfed baby presented to your office with complaints of irritability and sleepiness. Mother reports that she tries to breastfeed but does not suck well and has not been eating at all in the last 12 hours. On physical examination, patient did not look bad except for a dry mouth and a protruding tongue. So, this guy's dehydrated, right? I mean, kind of obvious. But what I'd like to draw your attention to is the sodium values. You remember before, I think it was what, 121? Okay, so now the patient has a sodium of 170. But it's the same, right? It's dehydration. So how can you have such profoundly different osmolarities? And I think the answer is pretty straightforward, isn't it? In the first case, the guy was losing sodium in excess of water, and here, the guy's losing water in excess of sodium. And the one thing that I would like to point out, let me give you that back before I break it. The one thing I would point out, and this is really obvious, but it catches a lot of people out, is there are two things that make for a high or a low sodium. One of them is sodium. What's the other? Water, yeah. So very often, total sodium is often fine, but any aberration in sodium, you often have to think, hey, we've got a water problem, not a sodium problem. Okay? So it's just kind of a heads up on how to deal with some of these things. So that gives us a feel for basic fluid shifts. What we're going to do this afternoon, and we'll take a break in a minute. What we're going to do this afternoon is we're going to delve into some more clinical aspects of fluid balance. I mean, what we did here, we did for the STEP exam, yes? Kind of. But now we'll try, this afternoon, we'll try and talk about things that are perhaps more clinical import. And we'll talk about plasma osmolarity. We'll talk about how we distribute fluid between compartments. And then we'll figure out how we can intervene in terms of fluid replacement. Okay? So we'll finish a little bit early. Come back at 1 o'clock. 1 o'clock? Okay. All right. Questions? Yes, sir.
Can you explain to me again I guess I'm not quite getting why the sodium difference would be there between the two different dehydration cases.
Okay. So the question is, basically go through again how sodium can be different, very high or very low in dehydration cases. And it depends upon the mechanism of, it depends on the mechanism of dehydration. Okay, so, if it were just a straight dehydration, if I ate pretty well and didn't drink any water, I'd probably have a high sodium, right? Yes? Okay. If I had something like, now I was going to say diarrhea, that doesn't actually work. If I had a condition where I lost primarily sodium and the water was following it, then I would have a low sodium. Okay, and I'm trying to think of a dehydration state that you could do for yourself. I mean, certainly, I mean, there are certainly some hormonal conditions which will tend to do that, but it depends on circumstances. Okay.
And you said you brought up diarrhea. You said no, it's not part of it. Why?
Oh, I'm sorry. Okay.
Our patients have
Yeah. So diarrhea tends to be rather often an isosmotic loss, and so you tend to lose water in proportion to sodium. So very often you can be phenomenally dehydrated from diarrhea but have a normal plasma sodium. Okay. Okay. So the sodium is not necessarily indicative of any level of dehydration. But if it's very, very high or very, very low, it's likely to be fairly severe. Okay. All right. Okay, let's take a break then. Thank you.